Okay, let us move on now. Hope you are all back. Okay, let's move on. See, someone asked me about abscess again. Please see this very clearly. Small abscess, aspiration. Big abscess, suction catheter drainage. Abscess which has ruptured or abscess which is multilocular, you will do IND. Previous treatments, if they fail, like you aspirated twice, but it is coming back again and again and again, then also you can do IND. But this is what is clearly given in Bailey. So please, this is something you can rely upon. Someone just message me just now. And the last thing in endocrine we have to do is thyroid and men syndromes. We'll do that. Then we'll go to urology and general surgery. That is the last part. I think we are maybe 15-20 minutes behind schedule. So instead of 8:15, थोड़ा आगे जाएंगे. What is signet ring lobular cancer? Lobular is a variant of breast cancer. It is the more dangerous one. Okay. What is the diagnosis of the last question? This liquid collection raised temperature this, with the lactation is going to be a breast abscess. This is abscess. कोई दिक्कत नहीं. So nice. कोई बोलता नहीं है मुझे कोई दिक्कत नहीं है. हमेशा दिक्कत ही दिक्कत होती है. Thank you for your kind words and your cooperation more than anything else. Now coming to thyroid. Now I tell this in every class. Thyroid is one of the things which students study everywhere and understand nowhere. You study not just in medicine and surgery, but also in anatomy, physiology, biochemistry, pathology, pharmacology. And it's a total chaos. ENT, ophthal, Graves, ophthalmopathy. Get one concept very clear. When you're talking about thyroid gland problems, think on two fronts. One front is when the gland becomes enlarged. That is called goiter. Okay, answer my question now. I don't know why would he say that. Why not mastitis if cracked nipple is mentioned? Mastitis में fluid collection नहीं होती है यार मनोज. Okay, there is no fluid collection. Mastitis is just inflammation, right? Abscess is pus. Yeah, now he got it. Wonderful. So whenever you think of thyroid problems, think of two aspects. One is the gland becoming enlarged. Second is the function getting affected. And this can happen in various combinations. So when I say goiter, it simply means any enlargement of thyroid. All right. This will help you approach any clinical question that comes on goiter. Any enlargement of thyroid is going to be a goiter. Now, how does the gland enlarge? It can enlarge diffusely. Means पूरा का पूरा gland diffusely enlarge हो गया. That is called diffuse goiter. Multinodular means gland is okay in size. Some parts have some bulges. That is called multinodular goiter. And third part is solitary thyroid nodule. Solitary means just one part of the gland has a bulge or a swelling. Why they happen, there are many reasons, but understand the context to move forward. Diffuse goiter, the first concept, is this kind of an enlargement where the whole gland has become enlarged, can present with any of the functional abnormalities. Okay, so what I'm trying to tell you is study the gland in two aspects. One is the anatomy, other is the function. So this is the anatomical problem, diffuse enlargement. Functional problem means the gland can be euthyroid, means function is fine. The gland can be hypothyroid. The gland can be hyperthyroid. Much of demand. Okay, when the demand increases, okay, I don't know which part. It's fine. It's fine. Stuck now. Okay. Now okay. I didn't do anything. Huh? Okay. 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 So The gland will enlarge diffusely, and when it enlarges diffusely anatomically, there should be some kind of functional problem. Now, this functional change will either be euthyroid, hypothyroid, or hyperthyroid. So, first understand anatomical problem, functional effect. It can happen in any combination. Why will the gland enlarge diffusely, but you will still be euthyroid? This will happen in what is called as a physiological goiter. In physiological goiter, there is increased demand, puberty, pregnancy, stress, surgery. Demand is high, so TSH increases, gland enlarges to maintain your normal requirement. Once that demand goes, puberty is crossed, or pregnancy is over, baby is delivered, gland will shrink back. This is physiological. When will the gland enlarge? Despite enlargement, there is reduced production. When does this happen? Gland has become big, but it is not meeting your body's demands. This can happen in iodine deficiency goiter, or it can happen in Hashimoto's thyroiditis. You have studied autoimmune goiter, Hashimoto's. In Hashimoto, the gland gets inflamed, it is also getting damaged, so it will enlarge, but secretions will reduce. When will the gland enlarge due to hyperthyroidism? Hyperthyroidism कब होगा? With a diffuse enlargement. This will be seen in Graves' disease. In Graves, there are antibodies which will stimulate, and make the gland enlarge and hyper. So what I'm trying to tell you is, if you call someone as having Hashimoto's, you should actually say he has a diffuse enlargement of goiter and he has hypothyroidism. That is the correct way to label someone as Hashimoto. If you want to label someone as Graves, diffuse enlargement with hyperthyroidism. That is the meaning of Graves. This is the concept you need to understand when you are talking about goiter and its associations. So you are not looking to diagnose the disease as a name. You are trying to diagnose the disease as a problem in the anatomy and a problem in the function if existing. So this is diffuse goiter. This physiological goiter sometimes can undergo a multinodular transformation. So this multinodular goiter is usually a complication, a late stage of a physiological goiter sometimes. So what happens is, when the physiological goiter is supposed to shrink back, so you had a pregnancy, the gland enlarged, baby was delivered, the gland should shrink. Let's assume in that shrinking period, the mother got some complication, postpartum hemorrhage or whatever. So the TSH levels in this demand and stress periods will keep fluctuating. So instead of the gland shrinking back, it will shrink back abnormally. Some parts will shrink, some parts will not. If there is fluctuation in TSH. Because of this TSH fluctuation, you get a multinodular goiter. These nodules are usually degenerated nodules. Usually. Okay, they are the abnormal nodules. The tissue in between is normal. Since the tissue in between is normal, the person will usually be euthyroid. Usually. There is no reason for him to be hypothyroid. बीच का part ठीक है. सिर्फ nodules are non-functional. They are degenerate. कभी कभार, if this persists for a long time, this multinodularity, it can undergo hyperthyroidism later. By mistake, some of the nodules or some of the tissue can become hyperthyroid later. This is called as secondary thyrotoxicosis. Okay, this is called as secondary thyrotoxicosis. What are all these? This is the multinodularity which started as a physiological goiter before. Now it became multinodular. So this is MNG. The third is the easiest to understand, solitary nodule. In solitary nodule, again, all the rest of the gland is working fine. So usually the person will be euthyroid. क्योंकि बीच का सारा gland तो ठीक है, barring the nodule which may or may not be fine. So what can this nodule be? It can be a cyst. It can be an abscess. It can be a tumor, benign or malignant. Since the rest of the gland is fine, his thyroid status will be fine. Rarely, the nodule can be hyperfunctional, so the person can be hyperthyroid. This is called as toxic adenoma. All right, this is called as toxic adenoma. There is no way he can be hypothyroid because the rest of the gland is fine, right? ये सब तो function कर रहा है. So why should he become hypo? This is the only set of complications and only set of combinations you can get in thyroid disorders. Whenever you see a patient with a thyroid gland disorder, first ask yourself, is there a goiter? Is it diffuse? Is it multinodular? Is it solitary nodule? Then check his function. Is it U, hypo, hyper? Then you will get all the possible etiologies. And once you get the etiology, you know what will be the treatment. Okay? So this is how you should think that a multinodular goiter started from a physiological goiter, which did not shrink normally. So it became multinodular. Sometimes this multinodular, by mistake, can become hyperthyroid later. Can become later multinodular by chance. But this cannot start by itself. It has to start from a physiological goiter. That is a natural history. Okay, so physiological goiter can become fine. Physiological goiter can become multinodular. Multinodular will be euthyroid. It can become hyperthyroid later. It goes in that sequence. Yeah. So this is how you should think when you think of thyroid disease. Everything else in thyroid will be understood if you understand this. बस इसी में बिठाना है बाकी सब कुछ. So now see this question. A young male presented with a midline swelling in the neck. After 6 months, he had lymphadenopathy. And all of these are correct about this condition, except hypo only in diffuse. Yeah, means why should there be hypo in any other? Because the tissue in between is fine. So there is no reason for it to be affected. So a young male presents with a neck swelling and he has lymph nodes. Neck swelling with lymph nodes means it could be a cancer with metastasis. If you see this image, you see these cells. They are very typical. These cells have what are called as orphan any nuclei. Orphan any nuclei. Which means this is a papillary thyroid cancer, PTC. So what they are asking you is, all of these are correct about papillary thyroid cancer except lymphatic metastasis is seen. This is true. Histology shows this. This is unique. It shows orphan any nuclei. It also shows one more finding which are called as Samoma bodies. They are also seen in papillary thyroid cancer. They are called as Samoma bodies. Has excellent prognosis. Thyroid is the only cancer which has excellent prognosis. It's one of the few cancers which you feel, even if you get it, no problem. Because many times nothing has to be done. FNAC is not diagnostic. This is incorrect. FNAC is diagnostic. How do you diagnose it on FNAC? With these findings, right? Orphan any and nuclear. So when you say thyroid cancer, how will it present? It will present as a solitary thyroid nodule. Usually, it will be a solitary thyroid nodule. Usually, there are 3 types of thyroid cancers. One are called as differentiated, which are the true thyroid cancers, in which you have the papillary thyroid cancer, which is overall the most common type, 80%, and follicular thyroid cancer. That is the second type. Then you have anaplastic thyroid cancer. The name only tells you how dangerous it is. This is seen in elderly, and this has a poor prognosis. And the third, which is not actually a thyroid cancer per se, it is there in the gland, but it is not a true thyroid cancer. That is called as medullary thyroid. It does not come from the thyroid gland. It comes from the thyroid C cells, the parafollicular cells, which produce calcitonin. So these are the 3 groups of cancers. Obviously, the most common is the papillary thyroid cancer. And it has an excellent prognosis. Okay, the important risk factor is someone who got a neck radiation. He may be at risk of papillary thyroid cancer. it gives lymph node metastasis. Okay, and I already told you what you will get on histology. So patient will come with a neck swelling. All thyroid swellings or all goiters, how do you know they are a goiter clinically? What clinical finding tells you it is goiter? The swelling will move up when he swallows. Okay, the swelling moves up on swallowing. That is what will tell you it is goiter. There are very few neck swellings which move up on swallowing. One of them is goiter. Yeah. गला देख के नहीं, थूक निकल के. Tell him to swallow. Yeah. So clinically you come to know. Then you investigate. And when you investigate, you do FNAC, you will come to know it's a papillary thyroid cancer. The treatment of thyroid cancers per se is going to be total thyroidectomy. That is the treatment of choice, total thyroidectomy. And since you have lymph node mets here, you will also do a level 6 clearance. Normally, thyroid spreads to papillary thyroid cancer spreads to level 6 nodes. What are these nodes also called? Anterior group or level 6. What are they also called? These level 6 group nodes. Excellent, Sharanjit. They are called as lymph nodes of Delphi. The other name of these lymph nodes, they are called as lymph node of Delphi or level 6 nodes. They are in the central compartment of the abdomen, of the neck. So they are also called a central group. They are the ones where the thyroid cancer will spread. So you remove this in papillary thyroid cancer. Remember, if the thyroid cancer, ETC, is less than 1 centimeter, it is called as micropapillary thyroid cancer. What do you do in this case? Very small papillary thyroid cancer, less than 1 centimeter. Then what are you going to do? Hemithyroidectomy. No, in that case, what you are going to do is surveillance. So what I am trying to tell you is, patient knows he has a cancer. You know he has a cancer. Still you are telling, don't do anything. Kuch nahi hoga. Just every year come, you will keep checking, and mostly you will not require any surgery because it's a very slow growing cancer. It's not really a cancer per se. Okay, so you are going to do surveillance for this micropapillary thyroid cancer. And the other common cancer is follicular thyroid cancer. This is the second most common thyroid cancer. Okay, this is also a true thyroid cancer. This is seen in people who had a prior multinodular goiter. For someone with this MNG, this can undergo cancer also. That will be a follicular thyroid cancer. And this has hematogenous metastasis. It commonly spreads by the blood-bone route to the bones. Okay, bone metastases are common. Further, when I do FNAC, it will not differentiate whether it is benign or malignant. So FNAC is not very diagnostic. It will just show me follicular cells. For definitive diagnosis, FNAC is not enough, which is why before surgery, I don't know whether it is benign or malignant, and biopsy is contraindicated in goiter. You don't do biopsy, you only do FNAC. So there is no role of biopsy. So in this case, what you are going to do is, if the tumor is only on one side, let's say the tumor is here, then what you are going to do is, you will remove half the thyroid gland and do a frozen section, like you do sentinel lymph node biopsy. So you are going to do hemithyroidectomy plus frozen section. Frozen means intraoperatively, you do a pathological assessment and you come to know whether it is benign or malignant. If it is benign, then that is the end of the story. Nothing more needs to be done. If it turns out to be malignant, then you will do total thyroid. All right, that's how you are going to manage papillary and follicular thyroid cancers, because in follicular, core biopsy ka option is not there. So no, you don't do biopsy. Biopsy is not done in goiters. You only do FNAC. There is only one exception to the rule, but I don't think you need to know that. So this is what you should do when you do talk about management. Hemithyroidectomy frozen. Based on frozen section, you will decide whether to remove the whole gland or not. Right? So this is about papillary and follicular. After you have removed the tumor, papillary and follicular, what do you do next? This is the question. Patient has undergone total thyroidectomy. It showed PTC. What will be the next step? It was a nice question. What do you do next? You're all saying radio iodine scan. Yeah. Why radio iodine scan? What for? Why radio iodine scan? For what? Yeah, for metastasis. Thyroid cancer is one of the few cancers, and thyroid means only these two, only papillary and follicular. For these two cancers, I don't do staging. First, I remove the gland. Then I stage later, after thyroidectomy. So once I'm done with the surgery, after total thyroidectomy, so once I have removed the thyroid gland for cancer, for metastasis, to look for metastasis, I will do a radioactive iodine uptake scan. It's like a PET scan, but I'm using iodine. So it's like a PET scan of sorts, but I'm not using FDG PET. I'm using radioactive iodine. Which radioactive iodine? I use 123 or iodine 131. I look for metastasis. If metastases are seen, then I will do their ablation. Okay. If I see metastasis, I will do their ablation. So answer is going to be radio iodine scan of the whole body. It's like a PET scan, like how we do PET scan. Yeah, normally after 3 to 6 weeks. This is done for papillary and follicular only. Okay, after papillary, both, because both will have iodine uptake. So it is done for both, but only for papillary and follicular. So PTC and FTC. Not for medullary, because medullary is not a true thyroid cancer. It will not have iodine cells. It will not take up iodine. Metastasis will not be picked. So ultra mat karna. And anaplastic, there is no point because you are never going to remove it. So anaplastic radioiodine scan is meaningless. Only for these two cancers you will do. And they love asking nowadays about complications in thyroidectomy. They ask this a lot. So what can go wrong in thyroid surgery? The first and foremost is nerve injury, because there are a lot of nerves around the thyroid. If they ask you most common nerve injury, it will be external laryngeal nerve or external laryngeal branch of superior laryngeal nerve. This is the most common nerve injury. The most dangerous nerve injury, not most common, but most dangerous nerve to be injured, which जिसको हाल में कुछ भी नहीं होना चाहिए, is recurrent laryngeal nerve. And where does it get injured commonly? That is ligament of Berry. That is the ligament behind the thyroid gland. That is the site where the nerve gets injured. And if it gets injured on one side, unilateral, you get hoarseness. So one-sided unilaterally, RLN injury, you get hoarseness. If both are injured bilaterally, then the vocal cords will come in midline. He will get airway obstruction or stride. Right. So कुछ भी हो जाए, recurrent laryngeal nerve को कुछ नहीं होना चाहिए. Otherwise, it's a disaster. Even if it is one recurrent laryngeal nerve injury, it's a problem. Both are injured, he's screwed. Right. So nothing of this sort should happen. Second is injury to parathyroid glands. This is quite unique. Now, your thyroid gland has two arteries which supply it. One is the superior thyroid artery on each side. Other is the inferior thyroid artery on each side. And you know you have 4 parathyroids. They are like this. All the parathyroids get blood supply from inferior thyroid artery. So this artery only will supply. This artery only will supply. Whenever I'm doing thyroidectomy, I should ligate the artery is very close to the gland, like this. To remove the gland, first I have to block the arteries. So I block them very close to the gland. Normally, if by chance I don't ligate it here, if I ligate it here, and I ligate it here, so what will happen? Blood to the thyroid will stop, but blood to the parathyroid will also stop. No blood going to parathyroid also. So parathyroids will become ischemic. There will be ischemia of parathyroid. All four. If I do it on both sides, all four glands will become ischemic. So post-operatively, the patient will become hypocalcemic because parathyroids control calcium. If there is no parathyroid, person will get hypocalcemia. So patient will have perioral tingling post-operatively. He may even get tetany. This normally will manifest on post-op day 3 to 5. If this happens, you have to do, if you are suspecting patient has this, what you'll have to do is serum calcium and serum PTH levels. All right. And obviously they will be low. You give him calcium supplement. Right. You give him calcium supplement. If during surgery, by chance, intraoperatively, if by chance you remove the parathyroids and you can see it, intraoperatively you mistakenly removed the parathyroid glands, then what should you do? Like you remove the gland, you saw 2-3 pieces of parathyroid also came with the gland. Galti se, aggressive surgeons. Yeah. Place it back. Where? In the arm. Why? Why in the arm? Kaigo? I was sure you will say the arm. Why in the arm? Arm if malignant risk. No. Please understand. You have removed normal parathyroids. Galti se. I never said so. मैंने नहीं बोला. At least मैंने नहीं बोला. Please understand. If you have removed normal parathyroids, they are normal now. You will place them in sternocleidomastoid. So place them in the neck, in the sternocleidomastoid muscle. Okay. So आप लोग बोल रहे हैं ना arm में, those are not accidentally removed. Those are glands which are diseased. Sometimes you get a disease. It is called multiglandular hyperplasia of parathyroids, where you intentionally remove all the 4 parathyroids by intention, not by mistake. Those are tumorous glands. Those glands, one small piece you put in the left brachial. Okay, because they are disease glands. So the part that you put back will still have some hyperparathyroidism tissue. If I want to remove it later, it will be easy. These are normal glands. You don't have to put them here. Okay, please don't do that. In real life also and in exam also. Original बचा ही नहीं ना. Original position पता ही नहीं है. Where do I put it? It should get blood supply from somewhere. So I put it in the muscle. Muscle will give it some blood supply. If they are tumorous, then you put them here. Okay, which is obviously not the case over here. And the third complication, which is again a dangerous complication, is hemorrhage. Sometimes what happens after I have removed the gland, there is by mistake post-op bleed. This normally happens within few hours after surgery, within 1 to 2 hours. So I did the thyroidectomy. I closed all the sutures. Patient was shifted to the room. When he reached the room after half hour, 1 hour, he coughed a little bit and then suddenly he started choking. He became breathless. That is post-operative bleed. Why it has happened? It's because of a hematoma which is compressing the trachea. If this happens, that post-operatively within 1 to 2 hours, patient gets breathless. After 1 to 2 hours, if he is breathless, it is a dangerous finding. He has to be shifted to OT immediately. Shift him back to OT. Because his trachea is getting compressed by the blood clot. So you should shift him to OT, to endotracheal intubation. Then you should remove all the sutures. in the neck and remove the clot. Remove all sutures and remove the clot. Till you don't remove the clot, he will continue to choke and he will die. Okay, so open the sutures, skin sutures, subacute sutures, facial sutures, see the clot, remove the clot, see if it is bleeding, stitch where it is bleeding, then close it. Okay, so clot has to be removed. You see a patient like this, it is a post-operative hemorrhage. Okay, this came in one of the other entrances, not an FMG, but it's a very important question. I feel these kind of questions will come. Normal person emergency choking treatment, you should know the reason. Did he swallow something? Or it happened just by chance? If it's just by chance, take him to hospital. On day 3, she developed perioral numbness. You will do calcium phosphate, and PTH levels. All right. And these are quite interesting. MEN syndromes. MEN stands for multiple endocrine neoplasia. They are syndromes where, because of some mutations, the person gets many cancers. They are called as multiple endocrine neoplasias. So you get a mutation and it predisposes you to many cancers. In MEN1, the mutation is in the MEN1 gene. It codes for the menin protein. What is the inheritance pattern of MEN syndromes? Inheritance pattern, and how have you remembered it? That's more important. How have you remembered it? All men are dominant. Men will dominate. No, that's not how you should remember it. Because men are not dominant anymore. It's because MEN syndromes are familial syndromes. You call them as familial MEN syndromes. Any disease in which the name is familial, hereditary, it is autosomal dominant. That's why it runs in families. Okay, because it runs in families. Not because men are dominant. It's not the right way to remember. Even HNPCC, hereditary, non-polyposis. Familial, adenomatous polyposis. Familial, colonic polyposis. So they are all autosomal dominant. Familial breast cancer, autosomal dominant. ऐसे पढ़ो. अभी ब्रेस्ट कैंसर कैसे याद रखोगे बॉर्का 1, है ना? वहां पर तो रट लिया, क्यों रटा वहां पे? They are all the same. They are all familial cancers. So they will be familial. They will be aggressive. Just like BRCA mutation, aggressive. They will occur very young. Young patients will get it. So you don't get it. This is seen in children. In MEN1, the syndromes that you are going to get is parathyroid hyperplasia. So this is going to affect all the 4 parathyroids. So it will be multiglandular. This is the scenario where you will do total parathyroidectomy and you will put one of the pieces in the forearm. This case. The second piece, pituitary, where typically you will either get non-functional tumor or you will get prolactinoma commonly. And the third piece, pancreatic endocrine tumors. जिसमें either you get non-functional endocrine tumor or you get gastrinoma. Okay, gastrinoma otherwise is not so common. It is common in MEN1 syndrome. Otherwise, in pancreas you get insulinoma. Okay, otherwise in pancreas you get insulinoma. Between the 3, which is the most common component of MEN1? Because everybody will not get all 3. You may get 1 or 2 of them because there is a lifetime risk now. So what is the most common between these? Yeah, it is PTH. Okay, that's why I wrote it first. Parathyroidism is the most common manifestation. It will be seen in 80 to 100% of the cases. Okay, the other 2 may or may not be there. Parathyroidism will be there. A variant of MEN1 is called MEN4. It has a different mutation. Everything else is the same. The mutation is in a gene called cyclin-dependent kinase inhibitor. Okay, CDKI, cyclin-dependent kinase inhibitor mutation. Just the name of the mutation is it. Okay, so that is MEN1 and MEN2. In MEN2, whether it is 2A or 2B, the mutation will be RET gene mutation. These will also be familial, autosomal dominant, aggressive, young, everything. Two cancers are common in both. Okay, two cancers are common in both 2A and 2B. One is going to be medullary thyroid cancer, other is going to be pheochromocytoma. They will be seen in both. Only the remaining components may vary. Like in 2A, you will also get the same parathyroid hyperplasia. This you may get. And in 2B, you get the rule of the M's. Patient may be marfanoid, or he may be having mucosal neuromas. He may have a megacolon. Right. These things may be seen, but the message is the first two, MTC and pheochromocytoma, are common to both. That's why they are subparts of MEN2 syndrome. This MEN2B is also called as MEN3. Okay, by chance, if they show you MEN3, it is same as MEN2B. Between these two, on the whole list, which is the most common in MEN2? Which of these tumors is the most common in MEN2? 2A, 2B combined. Overall, it is MTC. Okay, MTC is seen in practically 100%. Practically 100% of MEN2 syndromes. All right, pheochromocytoma is between 10 to 60%. So basically, if I have a parathyroid hyperplasia, I think of MEN1. If I have a MTC in a child, I think of MEN2. Okay, these are seen in children. So they occur so early, I do a prophylactic total thyroidectomy in these children if they are diagnosed. The thyroid is removed very early. Prophylactic total thyroidectomy at 5 years. 5 साल तक बच्चे का thyroid निकाल दो. In this case, you will remove it by 1 year. Because the MTC is 100% going to occur and will occur at a young age. So it has to be removed. Okay? All right. So that was your endocrine part, which we are done with. Now we go to urology. Okay, this part is done. Men 5 years may remove the thyroid. Men 1 may. In men 1 you don't do anything prophylactic. Till what age? Till what age? What? Take water. Thank you, Abhishek, for your kind cooperation. Okay. Sir, for revision, I made notes from FMG 6-day surgery class. Yeah, but there is not much new you will find. Most of the things are already there. Most of them. You should add new points from PYQs, you should add new points from QBank. Otherwise, nothing to add. That's what I want you to do. So these are some of the important things, some of them that they ask you. Urotrauma we already did. And CA testing is more for ionized CAT. For FMG, they ask more of the benign testicular disorders, which I will teach you. Okay, baki RCC, bladder tumors, CA prostate, Fournier's gangrene are all the same. Okay, prostate usually they are CA prostate. I'll show you what questions are there. Sorry, मैंने PYQ डाले हुए. We'll go first with uro-onco. Because by now, from morning to now, onco surgery तो आपको आनी चाहिए, right? So renal tumors are of many types, but the most common type is the renal cell carcinoma, RCC, which has many synonyms. के बहुत सारे नाम हैं. It is also called as hypernephroma. So it has many synonyms. Hypernephroma. It is also called as Gravit's tumor. Right. So these are some synonyms. Who gets RCC? किसको होती है आरसीसी? नो नो, नॉट डाई, डाई में नहीं होता वो ब्लैडर कैंसर होती है. दिस इज सीन इन एल्डरली स्मोकर मेल्स. सेम. So all those of you add one more to the list of the cancers, elderly smoker males. There are these pathological types. Clear cell type is the most common type. It is seen in patients who have a syndrome called VHL syndrome, von Hippel-Lindau. Papillary type is the one which also shows psammoma bodies. Like you had papillary thyroid cancer. This will also show psammoma bodies. This is seen in patients who are on hemodialysis. This type of RCC. These are all pathological types. Chromophobe has good prognosis. And medullary is the one which is seen in children who suffer from sickle cell trait. Okay, not sickle cell anemia. This is going to be sickle cell trait. Erode bird something something erode. I don't know what is that. Bird decay hog. Why would you write that? Such dangerous things. So, what will tell you that he has RCC clinically? When will you think patient is having RCC in your scenario? Bird decay hog. Okay, I don't know what that is. So important thing, they will tell you he is an elderly smoker male and he is going to present with painless profuse hematuria. Okay, profuse. The key word is it will be profuse or it will be gross. So much so that the patient will say he passes blood clots. Painless profuse hematuria in an elderly smoker male means it is either RCC or it is bladder cancer. Okay, either RCC or bladder cancer. These are the only two causes. Someone with a UTI, someone with a renal stone gets little hematuria. They don't get gross hematuria. They will never pass blood clots. Okay, be very clear about this. He may have a lump in flank. Right, the flank lump may be there. And in the late stages, he may get some pain. He may get metastasis. Usually, the metastasis in RCC. Now see, there is no portal vein here. So RCC will not metastasize to this. It will metastasize commonly to lungs. All urocancers go to lungs. And the metastasis is called as cannonball mets. Multiple cannonball mets. Okay, those are what you are going to see in RCC. So patient can have bilateral chest pain, all those things. So if patient comes with painless profuse hematuria, what is the first thing you are going to do when you investigate? In anything in urology, patient says hematuria, cross hematuria. What do you do first? No, not KFT. KFT is done in medical renal disease. First thing you will do always will be urine routine microscopy. Everything in urology, urine routine microscopy. This will show you blood in urine. You can do urine cytology. It may show you cancer cells. May show you cancer cells. Then you will do some imaging. To begin with, the first imaging that you will do will be USG abdomen. Actually, you will do USG KUB. It may show you the tumor, but I don't know whether it is benign or malignant. To prove that it is a cancer, what should I do? CT with biopsy, USG with biopsy, MRI. What to do? Not biopsy. GIT में तो बायोप्सी करा, ब्रेस्ट में भी बायोप्सी करा, थायराइड में FNAC करा. यहाँ पर आप CT कर रहे हो. CT. इतने CEC मत डाल. No biopsy. Why no biopsy? You don't want to do biopsy? No need. So the investigation of choice is CT abdomen, no doubt. And you are right, biopsy not needed. It's not that biopsy can't be done, it's that biopsy is not needed because this is again an imaging diagnosis. Imaging will tell you it is a RCC. Okay, I don't need biopsy to tell me. But what about metastasis? How do I look for mets? local mets, regional mets, lymph node mets, distant mets. So one thing I did was CT scan. That was for local mets to look for IVC invasion, because RCC spreads into IVC quite often. I will do MRI venogram. Okay, and then to look for distant mets, yeah, that is PET scan. So this is one extra thing, that RCC very commonly goes into the renal vein. From renal vein, it goes into the IVC. So if it goes into the IVC, I need to know. For that, I will do a MRI venogram. It will tell me presence of tumor cells in the IVC. The last part, the easiest part. This is the part that will help you understand every uro cancer. All uro cancers we study like this. Do stage, do treatment. Since this is a solid organ tumor, I have the T stage, which will be T1, T2, T3, which has T3A, T3B, T3C, and T4. यूरो कैंसर्स का स्टेजिंग ट्रीटमेंट, ओके, यूरो कैंसर्स का स्टेजिंग ट्रीटमेंट इज व्हाट यू शुड सी लास्ट में. मोनोग्राम नहीं है, वीनो है. इट्स नॉट लुकिंग लाइक मोनो, आई एम श्योर. वीनो. Now what is T1 RCC? T1 means tumor size up to 7 centimeters. This is divided in two parts. There is a T1A and T1B. T1A is up to 4 centimeters and T1B is more than 4 up to 7 centimeters. T2 is more than 7 centimeters. So T1, T2, easy to understand. Less than 7, more than 7. T3A is the tumor is spreading into the renal vein on the same side. This you will see on MRI. T3B, tumor is going into the IVC, but IVC part which is below the diaphragm. And 3C, it is going into the IVC part beyond the diaphragm. Means from kidney, renal vein, IVC, all the way to the heart. T4 is tumor which is going to breach Gerota's fascia. All right, this is going to be T4. So this is the classification based on size and local spread. Treatment part is quite easy if you apply some common sense. A very small RCC up to 4 centimeters, you can do a partial nephrectomy, which is also called as nephron sparing nephrectomy. So you can do a partial removal. More than 4 centimeters, but less than 7 centimeters, you can do partial nephrectomy or you can do radical nephrectomy. Both options are available. You know what is radical nephrectomy? Kidney with the lymph nodes. For these T2 and T3, there is only one option, that is radical nephrectomy. And for T4, you can do palliation. Why not give neoadjuvant chemo? Why not give neoadjuvant chemo? If it's very big. So these tumors, unfortunately, are chemo and radio resistant. So surgery is the only treatment option. They are chemo resistant. They are radio resistant. So luckily or unluckily, at least for exam purpose, you only have surgery. Nothing else in the treatment of RCCs, right? So this is how you should study every cancer in urology. Stage treatment, stage treatment, stage treatment. Adrenals preserved? No. In radical nephrectomy, they are not. All right. If bilateral, then you should do partial nephrectomy on the side where the tumor is smaller. If it's bilateral. That is why I gave this, na? Partial or radical. So this partial will be done if it is bilateral. Otherwise, why to keep partial? VCD, not very beneficial. Okay, answer this. Patient presents with a left lumbar region mass. He was found to have a mass of 8 by 5 by 3 centimeters confined to the kidney. What will be the treatment of choice for this case? So this is excellent. Someone wrote this T2. It will be radical nephrectomy. Okay, radio chemo are not going to be given. If it is less than 7 centimeters, you can consider partial nephrectomy if it's bilateral tumor. Okay, a few words about this. Let's see if you know what this is. Since this is a PYQ. A few words about this. What is this nephroblastoma? कौन सी बीमारी है? Yeah, nephroblastoma, commonly known as Wilms tumor. Okay, commonly known as Wilms tumor. This is what is seen in children. It's a tumor of the kidney which is arising from the nephroblasts. Blasts are the precursor kidney cells. It is normally seen in children between 2 to 5 years of age. It does spread by lymphatics. It can give lung mets. Chemo and surgery are going to be done both. So this is chemosensitive. Wilms is chemosensitive. But it is not the most common intra-abdominal malignancy in childhood. The most common intra-abdominal malignancy in children is not a nephroblastoma, it is neuroblastoma. Neuroblastoma is the most common cause of lump in abdomen in children. Okay, in children. This was the option in exam. This is the option which was given in the recall that I got. Yeah. So chemo and surgery is used, right? Okay. Now come to another very nice, very simple, very misunderstood topic, that is CA prostate, which I will really simplify it. Very simplify. That is CA prostate. Thoda I will tell you about benign enlargement also. To understand CA prostate, you should understand where is the prostate, how does it look. Okay, it will make your life very easy. So where does this prostate lie? Obviously, it is only seen in men. It is seen just below the bladder neck, over here. And I told you, here will be your pelvic floor, levator ani, which also has the external sphincter. जो आपकी external sphincter होती है, it is over here. This is the external sphincter. This is where the internal sphincter is, in the bladder neck. Okay. Now, if I take a cross section through the prostate like this, and I take a slice and I look at it from the top, how is it going to look? It looks like this. So there are two lateral lobes. Okay, these are what are going to be the lateral lobes. Between the lateral lobes will be the urethra. This urethra, prostatic urethra, in between the lateral lobes. Underneath here, this one is going to be the median lobe. There is only one, that is median. And सबसे बाहर, outermost, over here, this will be the posterior lobe. So the prostate has all of these lobes with the urethra in between, and somewhere between the lateral lobes like this, these ejaculatory ducts are going to come, which come from the seminal vesicles. Now understand what happens in which part. Anterior lobe नहीं होती, anterior groove होती है. There is no anterior lobe. There is an anterior groove. When I say benign enlargement of prostate, BEP, it comes over here in the lateral lobes, also called as the transition zone. This is where you get the BEP, benign enlargement. And as you can see, it will compress the urethra very easily. So BEP arises in the lateral lobes, also called as the transitional zone. And this will cause urethral obstruction or bladder outlet obstruction. So if an elderly man presents with symptoms of urethral compression, like frequency of urine, urgency, nocturia, those kind of symptoms are going to be seen in benign enlargement. On the other hand, CA prostate arises over here. This part. This is where you get CA prostate. Just see how far it is from the urethra. It is very far. So CA prostate is never really going to cause bladder outlet obstruction. So posterior lobe is the site of CA prostate. It is also called as peripheral zone. That is the other name. Peripheral zone. Because it is so far away, it will not cause bladder outlet obstruction. So then how do you diagnose or how do you identify someone having a CA prostate? If it is not going to compress, late, how late? पहुंचेगा ही नहीं इतना अंदर. How do you diagnose it then? Push is saying late presentation. Yeah, so these tumors will be diagnosed either when they are metastasized or by chance. Means you have to hunt for them. So any elderly male after 65 years should be screened for CA prostate because CA prostate is the most common cancer in men after 65 years of age. Most common cancer in men after 65. You have to hunt for it. If you hunt for it, you may find it. Otherwise, you have to look for metastasis. And you know where it metastasizes? Most commonly, it will metastasize to lumbar vertebra. Why are the Bateson's plexus? This was asked in one of the NEET PG exams. Bateson's plexus of veins is from where it will metastasize. So the clinical picture that they will give you is an elderly non-smoker man with lower backache with an incidentally diagnosed enlarged prostate or incidentally elevated serum PSA. Then you will think of CA prostate. Patient present with metastasis. They are not going to present with any symptom other than metastasis. Or you have to find them by chance, or you hunt for them. So how do you investigate? The first thing you do is a pore rectal exam. When you do pore rectal exam, you will feel a hard nodular prostate. This is your starting point in every elderly patient. Then you will do serum PSA. It should be elevated. A normal serum PSA is about less than 3.5. If it is between 3.5 to 10, you should do a biopsy. If it is more than 10, then it is suggestive of CA prostate. Okay, more than 35 means it is advanced CA prostate. So this gives you some clue about the diagnosis also. Then you have to confirm your diagnosis. Investigation of choice is going to be biopsy. Transrectal ultrasound with biopsy. The biopsy will turn out to be adenocarcinoma. What do you do after this? After you have diagnosed CA prostate? How do you look for meds? I am happy automatically you said metastasis. That's what I wanted to hear. So second part is going to be stage. To stage the cancer for local staging, you will do MRI pelvis. So prostate, bladder, rectum that we did in the morning, all local staging is going to be MRI pelvis. For metastasis, distant mets, you will do PET scan, including bone mets. You want to see bone mets also, na? You do PET scan. So now you come to know the TNM stage. Now TNM stage treatment. Ab wahi karna hai. Endorectal MRI is for rectal cancer. TRUS is transrectal ultrasound. Instead of doing abdominal ultrasound, you do rectal ultrasound. You put the ultrasound probe from the rectum, from the anal canal, and then you do the biopsy from there. Now, this is again a solid tumor. So, the staging will be T1, T2, T3, T4, and don't need to know each and every component. Okay, Just need to know the broad components and draw a line between T2 and T3 like this. And I'll tell you why. Draw this line between T2 and T3. Because here, there is nothing like early, advanced, metastatic. There are only two, early or advanced. Plus, if it is in this category, you can do surgery. That is called as radical prostatectomy. Okay, radical prostatectomy. Bus. If it is in this category, advanced, then there is no prostatectomy. Then you are going to do what is called as androgen ablation. Like breast is estrogen dependent, this is testosterone dependent. So if you give anti-androgens, the metastasis will reduce, the symptoms will reduce. Cystoscopic excision is for bladder tumors, not for prostate tumors, right? In androgen ablation, what can you give? You can give GHRH, like Gozerlin. That is one. Other is leuprolide. They are anti-androgens. Or you can give androgen receptor blockers, anti-androgen drugs, like flutamide or bicalutamide. So these are going to be androgen receptor blockers. They are only going to be used if it is advanced CA prostate. If it is early CA prostate, you go for radical prostatectomy. There is one exception to the rule. If it is a very old patient, means patient is more than 70 years, tumor is T1, his PSA is less than 10, and his Gleason score, you know, in CA prostate you put a score which is called Gleason. If his Gleason score is less than 6, in this patient you can do surveillance. Not because CA prostate is a good cancer, but because these are very old patients. Doing a radical prostatectomy may be too drastic. So just keep them on surveillance is also okay. But if you feel this is a little too hard to digest, simply remember radical prostatectomy for T1 and T2 cancers and androgen ablation for advanced cancers. Plus, this is what I want you to remember, because question will come from this. Like one question came. That's why someone was answering this. Patient was operated. Yeah, patient was operated for BEP. On evaluation, CA prostate was detected. He was found to have metastasis. What is the TNM stage of this case? What is the TNM stage? No, stage 4 nahi. I'm asking TNM stage. How are you saying T4? It is incidentally diagnosed. Incidentally means T1. N they have not given you, but they have told you he has metastasis, so this will be M. Okay. Stage 4 में ही पूछा था मैंने. I had asked T and M stage. So don't say distant metastasis is T4. T4 is adjacent metastasis. Oh, purposely I asked. So answer is going to be Gozerlin. Okay, this one, GHRH. Fine. So that was about CA prostate. Quite simple. Now it is simple. Bladder tumors are a very interesting group of tumors. They are the ones also which are seen in smokers, elderly smoker male. So elderly smokers, इसमें भी मिलेंगे. But they are also seen in people in certain occupations. Okay, it's an occupational cancer where you get exposed to certain chemical carcinogens. People who work in dye factories, textile factories, petroleum factories, rubber factories. When I work in these factories, I can inhale or I can be in contact with these toxins. They enter my bloodstream. They are all excreted in urine. And I told you, why does someone get cancer? They are excreted in urine. So when these toxins reach the bladder, till I don't mixture it, they will irritate the bladder while they are being stored. So every day if I work in these factories, every day my bladder is getting exposed to these carcinogens, I will get this cancer. आई बात समझ में? This is the meaning of occupational cancer. It is not something imaginary. It is something that is going to be correlated pathologically. Why bladder? Why not kidney cancer? Because kidney does not store urine. Ureters, urethra, they don't store urine. Bladder stores urine. Same as why you get cancer in rectum. By inhaling. They will be inhaled in your bloodstream. In lung से bloodstream में जाएगा ना. When you have cigarette, push. The nicotine goes to your brain, na? And eventually it gets eliminated. Where does it get eliminated? In your urine. Why nicotine? दूसरे माल जिसका यूरिन में टेस्ट करते हैं टॉक्स स्क्रीन वो आएंगे ना यूरिन में. वाई निकोटीन अच्छी चीज है मारो. यूरिन टेस्ट करते हैं ना एथलीट्स का वही है. So they are all eliminated in urine. So it's an occupational cancer. Now, who gets it and how will the person present? This again is going to be elderly smoker male and he will present with painless, profuse hematuria. Same thing. Painless, profuse hematuria. He may have metastasis. इसमें भी आपको bone metastasis, lung metastasis मिल सकते हैं. Same way. अफीम करो नशा मत करो. So what are you going to do when patient presents with painless profuse hematuria? The first investigation you are going to do will be urine routine microscopy, just like you did before. It will show blood. You will do urine cytology. It may show transitional cells because this is a transitional cell carcinoma. So transitional cell tumor cells may be seen. Then you will do USG KUB. It may show you tumor in bladder. May. Either you want to see in bladder or you want to see in kidney. Painless profuse hematuria in an elderly male, bladder, kidney. So I do USG KUB. I may see tumor in bladder. What do you do next? What do you do next? Painless profuse hematuria, USG KUB. MRI pelvis local. Excuse me. ट्यूमर कहाँ है? इसमें नहीं करना है आपको CT scan, biopsy. नहीं, I have shown a picture right here. Use this picture. No, the investigation of choice is going to be cystoscopy with excision biopsy. It is also called as TURBT, transurethral resection of bladder tumors. So I see this tumor and I excise it from the base. After excision, it looks like this. I need to do this so that I know the T stage. If possible, I should excise it. Then I look for metastasis. Metastasis, you know, I will do MRI pelvis and PET scan. ये पार्ट आता है आपको भी. अभी कोई आपको नींद से भी उठाएगा, you will be able to answer. You will not have to wait for Oppenheimer to summarize it for all of us, right? तो ये आ जाएगा अभी. इतना तो सीखिए पूरे दिन में. किसमें SCC कैंसर होगा ब्लैडर का? If the bladder undergoes squamous metaplasia. इतना कॉमन नहीं है, but SCC bladder, since you are asking, SCC is going to be seen if person has TB of the bladder, or if he has stones in the bladder, or if he got this infection called bilharziasis. India में नहीं होता bilharziasis. In patient में you can get SCC. So you did all these fancy things. Foley's catheter also need to be put after surgery. Yeah, because there will be some clots forming. Adeno not so common. I can tell you it is seen in ectopia vesicae, but let's not go there. बहुत तुम्हारी appetite में तुम इतना लोगे तो तुमको बदहाजमी हो जाएगी. TURBT is called transurethral resection of bladder tumor. Okay, transurethral resection of bladder tumor. That is called TURBT. See, till I don't resect it, how will I know how deep it is? Because the depth will determine the T stage. So the staging is again T1, T2, T3, T4. Now what was T1 in GIT? What was T1 in GIT? GIT? Mucosa, submucosa. Bladder में submucosa नहीं होता. Bladder only has mucosa. There is no submucosa. T2 was muscularis. T3 in esophagus was adventitia. You are seeing now how similar it is. And T4 was adjacent organs. So 100 बात की एक बात, T of bladder is same as T of esophagus. Same to same. It is the same T stage as you had in esophagus. So instead of ratta maroing, you got the answer. Right? This mucosa part na, is further divided into TA and T1. If you remember, fine. If you don't remember, it's okay. Nobody is going to kill you for it. In T1, it is mucosa and invasion of lamina propria. Okay. It also involves invasion of lamina propria. In TA, lamina propria is not involved. This is what they give. पहली बार staging she लग रही है. She मतलब गंदी या she मतलब सही. I hope it means अच्छी and not गंदी. She, हे भगवान. अच्छा, no, सही. Arpita is saying she. She is saying सही. She कैसे अच्छी हुई यार? ये कौन सी भाषा है? She. I'm getting scared now. Did I overcomplicate it instead of oversimplifying it? Okay. Anyways, now come the treatment. Now, bladder gives you this advantage that it is very locally accessible. Like you got the chemical carcinogens to cause the bladder cancer. If the tumor is superficial, you can use this to your advantage by giving direct chemotherapy. You don't have to give it IV or oral, direct chemotherapy. So how do you treat these bladder tumors? If it is an early bladder cancer, only mucosa. First you did the excision, first you did TURBT. After that, you don't have to give systemic chemotherapy. You can give direct chemotherapy in the bladder. That is called as intravesical chemotherapy. Intravesical chemo, not systemic chemo. This intravesical chemo, you can give mitomycin, or you can give intravesical BCG, TB vaccine wala BCG. They will act directly on the cancer cells in the bladder wall. Nothing needs to be done, just this. So easy. Obviously, if the tumor is invading muscle or adventitia, means it's a deep tumor, local chemotherapy will not kill that. In these cases, you have to do radical cystectomy. Means you have to do radical bladder removal. Whenever I will remove the urinary bladder, okay, he needs some alternate pathway for urination. Because now bladder is gone. How will he pass urine? So whenever I do a radical cystectomy, I do something that is called as ileal conduit. This ileal conduit is like a new bladder for him, from which he will exit the urine. So I do ileal conduit. That is how the urine will come out. This ileum is made into a bladder. It is brought out like a stoma. If it is advanced, you will do palliation. Right? So this is how you are going to treat. In the exam, what they will ask you is, they will either give you a non-muscle invasive bladder tumor and ask you the next step, or they will give you a muscle invasive bladder tumor and ask you the next step, like this question. There is a question, this one. This T stage is based on pathology, yeah. It is based on excision biopsy. Biopsy staging. Okay, see, patient presents with painless hematuria. He is having bladder cancer up to muscle layer. What will you do? If it's muscle invasive, please don't give intravesical treatment. The best answer is going to be radical cystectomy. Okay, radiotherapy bhi de sakte hain. That is the next best answer. Even radiotherapy is given for bladder tumors. But the best answer will be radical cystectomy. Okay, so those were some Euro-Onco topics that we did. Now we'll do some benign topics in Euro, and then we go to whatever is left in general surgery. So one is going to be urinary tract tuberculosis. Very, very nice, very important topic. Please understand, urinary tract TB starts in the kidney. Okay, and where it is coming to the kidney from, it is coming from lungs. So from lungs, hematogenously, the primary TB will spread to the kidney, and in the kidney, it will reach the glomeruli. And from the glomeruli, it will enter the kidney substance and start damaging the kidney slowly, slowly, slowly. So first you will get kidney में ulcers. Then you will get cavities. Then slowly, 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 whole kidney will become replaced by caseation necrosis. That is called putty kidney. Means whole kidneys become filled with pus. Caseation necrosis. This putty kidney will eventually get calcified and form cement kidney. So slowly, 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 the bacilli is taking full फायदा of your kidney. So धीरे 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 करके the whole kidney is getting eaten up by the bacilli, from ulcers to big cavities. Then the whole kidney has become pyonephrosis. Then the bacilli enter the pelvis, enter the ureter, and from the ureter they go into the bladder. So once they reach the kidney, then they enter the renal pelvis. They enter the ureters, where they start forming stricture. Okay, this appearance of ureter is called as lead pipe ureter. So as it has started from kidney to ureter. From ureter, it will reach the bladder. In bladder, it will affect the bladder orifice, the ureter. That appearance of the orifice is called golf hole orifice. So you get a golf hole ureteric orifice. The whole bladder will start becoming fibrosed. That is called as thimble bladder. I'm telling you these names because these are the terminologies that will feature in your exam. Okay, golf hole ureteric orifice is seen in, thimble bladder is seen in, putty kidney is seen in, cement kidney is seen in, lead pipe ureter is seen in. All of these are pathological changes one after the other. You see this image? What is this imaging modality? What is the modality? Forget the finding. What is this imaging modality? Is it a X-ray KUB, IVU, retrograde ureterogram, micturating ureterogram, IVU? Okay, wonderful. Okay, see, all mixed answers. Because you see this, you are calling it a IVU. Let me be very clear, it is not an IVU. To call something as an IVU, I should see contrast in both the kidneys. I see contrast in none of the kidneys. I should see the ureters. I don't see any ureter. If there is contrast given, where is the ureter? At least I should see contrast in the bladder. I don't even see the bladder. How is it an intravenous urogram? Which means this isolated speck of radio opacity is a calcification in the kidney. This is a KU. Whenever you want to say IVU, please look for white bladder or white ureters. If none of them are seen, it is not an intravenous urogram. Okay, please don't make this mistake. Because to get IVU, contrast should be given somewhere. Okay, contrast should be given somewhere. I don't see any contrast anywhere. How is it IVU? This is the plain KUV. What it is showing calcified kidney. All right, this calcified kidney, someone is asking putty kidney or cement kidney, go for cement kidney. But one of the two only will be there. Both options won't be there. What is this image? What is this image? cobra, bladder TB, not cobra, excuse me. This is your small bladder. Just see how small it is. You can see pubic symphysis इसके size का bladder है. And you can see these ureters. Nice big ureters. So this is IV. And this is showing thimble bladder. Thimble means a bladder which has become small and contracted because of tubercular fibrosis. TB will cause ulcers, strictures, fibrosis, bladder will become shrunken. That is called a thimble bladder. To diagnose this, you are going to do urine routine microscopy, in which you get a very classical finding called as sterile pyuria. Because tubercular bacilli are not normally seen. You have to do special tests to look at the bacilli. So this is going to be sterile pyuria. This is what you see. If you see sterile pyuria, the next thing you are going to do is you will take 3 consecutive urine samples in the morning, early morning urine samples. And these 3 samples you will send for TB examination. You will send them for TB tests, like Gene Expert or CBNAT. You may have heard these, Gene Expert, CBNAT, these kind of tests. They will tell you there is TB. To know the extent of injury in tuberculosis, you will do CECT abdomen. It will tell you how much is the damage. Is it only in the kidney or in the ureters or in the bladder? So you do CECT abdomen, abdopelvis. You come to know the extent of damage. And last May you are going to treat. Treatment is going to be ETT. All right. Treatment is going to be ETT. So that is about renal TB. This treatment of renal stones, let me give you a little break. We'll come back in exactly 10 minutes. It is 7:45. 7:55 will come back. Then we will finish urology and whatever is left. I think by 9 o'clock, we are on track for 9 o'clock. So little extension. Why CECT? How do I see all this? Is there putty kidney? Is there ureteric problems? Is there bladder problems? तो देखने के लिए CT करना पड़ेगा. So you do CT abdomen plus pelvis. Right? That will tell you extent of injury. Hello guys, come back. Now I know Oppenheimer speaks Gujarati. ऑस्ट्रेलिया 6 मोच कर भाई मोच कर. No, I'm not Gujarati. Do I look Gujarati? I don't think Nasta is a Gujarati surname. No, I'm not Gujarati. I am Sindhi. I met Oppenheimer in offline BTR. You didn't meet him in offline ORR? Okay, anyways. Chalo, let's move on. No, I've not had my dinner. It's too early. सर्जन अगर 8 बजे डिनर करने लगेंगे ना खत्म सर्जरी नहीं होगी फिर. मैडम इज डूइंग क्वेश्चन बैंक वर्क. शी इज मेकिंग अभी एक जीटी आ रही है ना आप लोगों की अगले हफ्ते. तो उसकी क्वेश्चन बना रहे हैं हम लोग. उसकी रिकॉर्डिंग भी करनी है. वी हैव टू गिव रिकॉर्डेड सॉल्यूशंस एंड सर्जरी एवरी एफएमजी जीटी 33 क्वेश्चंस आई हैव टू गिव. टू मच. इजी पढ़ा ना एकदम इजी. all I'll put all surgery will be one liner only. They are asking are you moderate level like okay गई मैम गई. Someone was remembering her, na? Okay, let's start. Now, renal stones, what you need to know, the first thing that they will ask you in the exam are the different types, how they look. At least the microscopy you should know, right? At least the microscopy. So, oxalate stones are the most common renal stones. And microscopically, they have two appearances. Either they will be envelope shaped, the crystals, or they will be dumbbell shaped. So these crystals, you should know how they look in urine. And because they contain calcium, anything like calcium, like bone, will be radiopaque. On the other hand, the triple phosphate stones, which are also called as staghorn stones, because they fill the entire renal pelvis. Microscopically, they are going to be coffin lid. Their crystals will look like coffin lid. And because they contain calcium, magnesium, ammonium, they will also be radiopaque. Right? Uric acid crystals, uric has 4 letters. So uric acid crystals will have 4 sides like this. They will be rhomboid shaped. And uric acid are going to be not seen on X-ray. They will be radiolucent and rhomboid. And cystine stones, cystine has 6 letters. They will be hexagonal. And cystine stones will be radiopaque, but not because of calcium, because of sulfur. Okay, sulfur is what will make them radiopaque. So barring uric acid stones, all else will be seen on X-ray and usually also on CT, right? So this is what you need to know about their appearances. Now coming to treatment. First, you want to diagnose where the stone is. So the investigation of choice for renal stones is going to be plain CT KUB, because these stones are seen on CT. So that will be the diagnostic test. Mind you, these renal stone diseases don't cause too much hematuria. The hematuria will be of a very small amount. So it will, some places you can't even see it. It is only seen on urine routine microscopy. Now, how do you treat the stones? I'm sure some of you may have suffered from these stones. आप में से किसी ना किसी को तो हुआ ही होगा, because they are very common, especially if you do a lot of, right? So yeah, Pankaj has suffered. Pankaj would not be doing that. No smoking, sir. I know. Beer से निकल गया. So to treat renal stones, first you do the emergency treatment if there is an emergency presentation. But if the stone is less than 5 millimeter in size, then it will pass naturally. Okay, with medical management, it will pass. Problem is for stones which are more than 5 millimeters. So one of the treatments is this procedure. This is called as ESWL, extracorporeal lithotripsy. It is non-surgical. Okay, it is non-surgical. This machine will throw the shock waves. They are sound waves. They will go and hit the stone and fragment the stone. So it's not really surgery per se. This is going to be done mainly for stones between size 5 to 20 millimeters. Those stones can be broken down. They should be soft stones. So when will ESWL not work or contraindications? Contraindication will be stone more than 20 millimeters. If the stone is a hard stone, usually cystine stones won't break. And if the stone is in the lower calyx, lower callicial stones can get stuck in the renal pelvis. They may not pass. And obviously, you can't do ESWL in pregnancy. It is an absolute contraindication because the shock waves will also shock the fetal skull. Fetal skull will also break with the stones. So obviously, you can't do ESWL in those cases. Right. On the other hand, cysteine, I don't know who taught you like that. Sulfur bonds are the disulfide sulfur bonds are what make it strong. Okay, those bonds don't break like my bond with some of you, unbreakable. These are the sulfur bonds in cysteine. That's why cysteine is resistant to ESWL and not cysteine. Okay, if you remembered it by some mnemonic, it's not the right way to remember. The disulfide bonds don't break. Okay. And when I can't do ESWL, I do this. This is a surgery. This is done only by a urologist. Nobody can do it. General surgeon, radiologist, they don't do all this. Okay, this is only done by urologists. This is called PCN. Percutaneous nephrolithotomy. Okay, I want you to focus on this word, nephrolithotomy. Whenever I say lithotomy, it means to remove the stone. Okay, lithotomy means to cut open the stone and remove the stone. In ESWL, the L stands for lithotripsy. Tripsy means break. There is no removal. अपने आप वो उसके टुकड़े टुकड़े पास हो जाएंगे. In PCLM, I am actually removing the stone. So through the skin, you pass this nephroscope into the kidney, into the pelvis. You pass instruments, you break the stone, you take it out. So you can break any damn stone with this. Hard stone, soft stone, suck stone, very sucked stone, everything can be broken. So it can be used for any scenario. Usually, the indications are going to be where I can't do ESWL, more than 20 mm stone. The stone is very hard. It is a sucked or a hard stone, like a cystine stone. If it is in the lower calyx, I can do it. Right? There are no real contraindications. Okay, there are no real contraindications. Pregnancy is a relative contraindication. Okay, so pregnancy, obesity, they are scenarios where it is difficult to do PCN. Right? So these are the two main surgeries where you are, or rather the two main scenarios where you will do surgical interventions for renal stones. Okay, you know this more than enough. And the last scenario is if the stone has gone into the ureter. कभी-कभी kidney से slip होके ureter में जाएगा. In that case, what you are going to do is you will do ureterorenoscopic removal. You pass an endoscope from the urethra, bladder, ureter, and you remove it with the help of an endoscope. That is called ureterorenoscopy, also called as RIRS. Okay, it's a more advanced type of ureterorenoscopy that is called RIRS. PCNL से इंजरी हो सकती है, बिल्कुल हो सकती है, because you are cutting through the kidney, so there can be bleeding from the kidney. Just above the kidney here, just above it over here is the diaphragm. So you can puncture the diaphragm, the pleura. You can puncture the diaphragm, you can puncture the pleura. So yes, there can be injuries. But this is like the bread and butter. In PUJ, kidney ureter junction, you will do one of these two only because they are technically renal stones. Ureteric stones, ureterorenoscope. Okay, this question was asked in FMGE Jan. Patient came with pain. This image is obtained. First, tell me the imaging modality. What is this imaging modality? Just the modality. X-ray or IVU? I hope you are using your brains here and not some shortcut understanding. So, bladder is not seen, ureter is not seen, nothing is seen, kidney is not seen. All that you see is this. So obviously this is not intravenous urogram, the plain X-ray QUB. Now where is the stone in plain X-ray QUB? I'll give you a trick to remember. This is the sacrum, right? So just above the sacrum will be L5, then you'll have L4, L3, L2, L1. These are my lumbar vertebrae. Kidney normally lies, here will be T12 somewhere, and here is a 12th rib. Kidney normally lies over here. Okay, this is the normal location of the kidney. T12, L1, L2, little away. The ureter starts over here. L2, 3, 4, 5. Then it goes into the bladder like this. So what you can see here again, L2, L3, L4, L5 like this. And it goes into the bladder. So the ureter lies on transverse process of 2, 3, 4, 5 lumbar vertebra. So this radio opacity that you are seeing here, this one, is actually in the left ureter. So the answer is going to be ureteroscopic removal. Okay, ureteroscopic removal. RIRS can be done in cystine stones if the anatomy permits. Yeah, RIRS can be done. It can break the stone. ESWL will not break the stone. RIRS will break the stone. All right. So that was ureterorenoscopic removal. This is one of the most recently asked topics. 2-3 बार पूछा है उन्होंने. बहुत ही अच्छा टॉपिक है. ECNL में क्या इमेज होगा? इमेज यानी वो तो उसमें दिखता है ना, एंडोस्कोप से निकालोगे आप, नेफ्रोस्कोप से. So a boy presented to the OPD. His left scrotal sac is empty, and the left testis is in the superficial inguinal pouch. What is the most likely diagnosis? Now see what happens here. A very popular topic. They love asking this. Here we are talking about testes which has not come all the way down, undescended testes. Where does the testes get formed? It gets formed in the abdomen, in the retroperitoneum. Then slowly it comes out into the inguinal canal. Here you have the deep ring, here you have the superficial ring. So this testes will come into the deep ring, inguinal canal, superficial ring, then go down like this into the scrotum. This is the normal pathway of descent. If the testes lies anywhere in this path, means in the retroperitoneum, deep ring, inguinal canal, superficial ring, upper in the scrotum, anywhere in this path, I will call it undescended. Okay, I will call it undescended. So it will lie anywhere in this path. On the other hand, if the testes lies anyways outside of this pathway, now outside of this, now there are very unique sites. कहीं भी नहीं होती है. There are some unique sites where you will get the abnormally located testes. Like the testes, instead of lying in the inguinal canal, it lies over here, above the inguinal canal. That is called as superficial inguinal pouch. Or the testes can lie in the thigh. That is called femoral testes. Or it can lie at the root of the penis, penile testes. Or it can lie in the perineum. These are all abnormal sites. They are called as ectopic sites. So here the testes is in the superficial inguinal pouch. Answer is going to be ectopic testes. Okay, ectopic testes. Undescended testes commonly are going to be seen commonly in the upper scrotum. They are called as high scrotum. That's the most common site for undescended testes. They will be called as high scrotum. If high scrotal is not there, go for superficial ring. Okay, go for superficial ring. Retractile testes are normal testes. They are testes which temporarily go up. Okay, temporarily. Maybe because the child is very anxious and you touch his scrotum and the testes temporarily goes up. That is a retractile testes. It comes down by itself. Undescended testes will lie somewhere in the normal pathway. Ectopic testes will not lie in the normal pathway. They will be somewhere outside the normal pathway. Those are called as ectopic, like this superficial inguinal pouch. Normal pathway, retroperitoneum, deep ring, inguinal canal, superficial ring, upper scrotum, lower scrotum. That is normal path. Anywhere in this pathway, it is going to be undescended. Okay, आया बात समझ में? ठीक है? Sir, do we have to? नहीं नहीं वो करेंगे करेंगे करेंगे. Do we have to observe वाला part आना बाकी है. So these are the sites of undescended testes. These are some of the sites of ectopic testes. Now, before you go anywhere, answer this question. Oh, not this one. Where is that question? Okay. There was one question. I didn't put it here because I didn't feel it was right on the management. So when the child is born with undescended testes, what are you going to do? You will wait for 3 to 4 months to look for descent. In most cases, in 3 to 4 months after birth, the testes come down. If they descend down, very good. But if they remain undescended, so if they remain up, they don't come down, then you have to do surgery, which is called as orchidopexy. Orchidopexy means wherever the testis is, you pull it down into the scrotum and you suture it to the scrotum. Okay, that is called as orchidopexy. It's not always that you are going to be able to bring it down in one go. If it is very high up, like if the testis is in the abdomen, for abdominal testes, if you can't bring it down in one go, you may have to do it in 2 stages. That procedure is called as Fowler's procedure. Okay, when you bring it down in steps for undescended testes. Okay, but it has to be brought down. And if it doesn't come down for 3 to 4 months, you will do orchidopexy. The age of orchidopexy is 6 months. Yeah. But I am telling you why 6 months, because you wait for 3 to 4 months for it to come down. If it doesn't come down by 3 to 4 months, 6 months tak you have to bring it down. Okay? That is about undescended testes. Retractile testes, nothing needs to be done. Ectopic testes also have to be brought back down. Cryptorchidism means neither testis is clinically felt. Neither testis is clinically felt. Means both scrota are empty. दोनों तरफ खाली है. Okay, please clear this PYQ. Which PYQ? तो आंसर वेट एंड वॉच होगा ना सर. कौन सा PYQ है? वेट एंड मैंने कौन सा PYQ दिया अभी? ओके, बैग ऑफ फॉर्म्स वाला करना है. So if the patient presents very early, you wait till 6 months. If he presents at any age after 6 months, it has to be brought down. So even if it presents at 1 year, 2 years, 10 years, 20 years, you bring it down. When will you not bring it down? Like a patient comes at 10 years. Hormonal role not as per surgery books. Surgery books में तो नहीं. Yeah, in which case will you not bring the testes down? Even if the person comes at 2 years, 5 years, 10 years. No, not, yeah, if it is non-viable, excellent. When I look at the testes, if it is non-viable at any age, already it has become atrophic, then please don't bring it down, then you will do orchidectomy. Okay, so viable orchidopexy, non-viable orchidectomy. Fine, I have no doubt about this. So 5 years, 10 years, 20 years नहीं लाया तो आपको निकालनी पड़ेगी. If it is already gone, if it is surviving, you can still bring it down. Sum of all this in one go. Oh, okay. See, wherever the testes lies, when the mother will bring the child, she will say one scrotum or both scrota are empty. You examine, they are empty. You investigate to find where the testes is. Either it will be higher up or it will be in the abdomen. Whatever it is, if the age of the child is less than 6 months, you wait till 6 months. Then you do orchidopexy. At any age beyond 6 months, you will do orchidopexy immediately. Okay? Simple? Okay. What is this? This disease? This is called as varicocele. In varicocele, the testicular veins, these veins, they are called the pampiniform plexus. They are dilated. So it is a dilated pampiniform plexus of veins. This is seen in young boys. They are the testicular veins. They are tributaries. If they become abnormally dilated, there are various reasons for it. If they are dilated, they are going to be if they are dilated, they'll lead to a scrotal swelling. That is going to be varicocele. Now, before we discuss varicocele, solve this question. Young male, yeah, solve this one. No, not Prayan sign. Could we mix up mat karo? Young male like you will present with a dragging sensation. You can check if you're having dragging sensation. He will have a bag of worms feel. But the testes are normal. What is the diagnosis? This is going to be varicocele. Okay, bag of worms feel is very classical. Now, what is this bag of worms feel? When it dilates, the person gets some dragging pain because of the dilation. And when you are going to examine, you will see one scrotum is enlarged, and at the root over here, when you will palpate, it will feel like a bag of worms. So you do feel something like a bag of worms. This is very classical of a varicocele. They are more common on the left side. Don't worry about torsion. I will tell you what is torsion. They are way more common on the left side than the right side. They are going to be seen in young men, young like you. Okay, young men means young like you, in his 20s. Torsion is seen in boys, not men. Means 8-9 साल का लड़का, 10-11 साल का लड़का, उनमें होगा torsion. The investigation of choice to diagnose this is going to be testicular Doppler. So Doppler will tell you that the veins are dilated. And the treatment is going to be testicular vein embolization. You embolize the testicular vein, these छोटे veins will collapse. So that is the treatment. Right? Zoom user answer is C. Scrotum तो दोनों सेम ही दिख रहे हैं. वो क्योंकि अभी तक वो डायलेट हुआ नहीं है और ये रियल इमेज नहीं है ना, ये एनिमेटेड इमेज. So animated image, they will not give you full anatomy. Right? So it looks like this. I won't say in real patient, but in a caricature, it will look like this. 3 testicle appearance is seen in a different disease that is called spermatocele. 3 testicle is seen in a disease called spermatocele. A spermatocele is like a cyst. उसमें क्या होती है? At this epididymis, a cyst forms. So when I will do the imaging, what will I see? I will see one normal testicle, other normal testicle, and a third testicle, which is actually not a testicle, it is a cyst. That is why it is called 3 testicles. It looks like the person has got 3 testicles. Right? Palamo's operation not done anymore. It's an old operation. In which scenario will the person have 3 kidneys? Is there any disease where you get 3 kidneys? Spermatocele, nothing has to be done. You can excise it. But nothing needs to be done for it. PNM classification, yeah. Yes, until 1 year, we can wait. Okay. Wow, what is this? 9-month-old male infant. Left scrotum. What is the appropriate management? You marked. Okay. No disease but renal transplant. Yeah. So if I receive a renal transplant, I will get 3 kidneys, 2 of my own and 1 new kidney. So ultrasound pe if there are 3 kidneys reported, it means it person has received a renal transplant because we don't remove the normal kidneys when you are doing renal transplant. Okay, 9-month-old infant and brought for routine checkup. Pediatrician notices left testicle is not palpable. Handily, no signs of discomfort. What is the most appropriate immediate surgical intervention? Observe and reassessment at 12:1. No. Answer is A. Zoom user, your answer is right. Okay, and don't blame me if you have gotten a different answer. Answer is bring it down immediately for undescended testes. Ian, तुम लोग ना ओके हो गया जूम यूजर आगे बढ़ू मैं अभी ओके जूम यूजर ना डेंजरस नाम है अरे सी दैट्स नॉट फेयर व्हाट यू आर डूइंग this is a very smart strategy. Yeah, you're wasting everyone's time by doing this. Should bring it up with them. Anyways, boy presented an agony with severe pain in the groin with redness and swelling of scrotum. The right testes looks higher than the left. What is the diagnosis? This is a very classical finding. Okay, this is a case of torsion. Now, what will happen in a torsion? Torsion is going to be seen typically in young boys. 21 to bahut ho gaya. Normally, it is seen in young boys, usually in teenagers. Usually, आप लोग से पहले आप लोग को नहीं होगा अभी torsion. And why does it happen? There are some anatomical problems because of which the testes twists. So, because of twist, the testes will become ischemic. So the boy will present with acute scrotal pain. So it's very dramatic. It's nothing like varicocele, hydrocele, hernia. He will have acute scrotal pain. And when you will examine, there is a typical finding when you lift the testes, the pain will increase. This is called Train's test. Okay, when I lift the testes, the pain will get worse. The child will cry more in pain. This is called Train's test. And what you see here, the affected testes is lying higher. That is called as Deming sign. This that you are seeing in the question. It's called Deming sign. So this is a testicular torsion. What do you do in testicular torsion? Ideally, you have to untwist it. So for that, you open the testes, open the scrotum, and ideally you should untwist it within 6 hours. Okay, that is the typical limit. If the child comes beyond 6 hours, when you will explore it, you will see that the testes is not very viable. Right? So ideally within 6 hours. Of course, the earlier the better. But that golden window is 6 hours. And after this, you will do contralateral orchidopexy. Means जो दूसरी testes है, उसकी भी orchidopexy करनी पड़ेगी because that is also at risk of undergoing torsion in the future. Okay, on lifting the testes, pain will increase. Yeah, increase, not reduce. Okay, इसमें investigation or choice नहीं पूछेंगे. They should not, because what Bailey says is you can do arterial Doppler, can do Doppler if in doubt. But that does not mean you will always do Doppler. If there is a clear-cut clinical evidence, you can straight away do scrotal exploration. But if there is a doubt, you can do Doppler. But they say, Bailey says, don't waste time in doing Doppler. Yeah. All right. So that was about urology. This topic is more general surgery. So now we are migrating from uro to general surgery. VVIMP topic. It's an easy topic, but it's VVIMP. What is Fournier's gangrene? It is a type of a necrotizing fasciitis, special type. It is a special type of necrotizing fasciitis. When I say necrotizing fasciitis, it means it's infection of skin, subacute muscles, fascia, up to fascia. This is going to be seen in patients who are diabetics, who are taking steroids, elderly, immunosuppressed patients. So elderly uncontrolled diabetic who comes with a scrotum like this is a Fournier's gangrene. Okay, elderly uncontrolled diabetic. Now, why does it happen? This will happen following trivial trauma. खुजली करोगे आप लोग आपको हो सकती है. So this happens following trivial trauma. Okay, if there is a trivial trauma and the skin is breached, the organisms will enter like staphylococci, streptococci. They will enter the skin. Now in you and me, even if we do khujli and the staphylococci enter, nothing happens, right? Because you have an immunity. But in these patients who have poor immunity, these organisms will flourish and they will cause a massive ineffective gangrene, a very broad spread infective gangrene. And because they are killing the tissue, they will allow the anaerobes to also multiply. So anaerobes will also start growing. So aerobes are helping the anaerobes. Like how Rehan asked about renal transplant and someone answered the question for him. So you helped each other. So one person is aerobe, other is anaerobe. You're helping each other. Oppenheimer, he has been the aerobe all day since morning. So aerobes are helping the anaerobes, giving a polymicrobial infection. That is why this is also called as synergistic gangrene. They are acting in synergy, right? So this is also called a synergistic gangrene of skull. This is the part that you need to know. Rest of the things are very easy. Elderly male will present with a scrotum swelling like this. What are you going to do? He will, when he presents with this swelling, please understand, he will be very sick because the infection is very bad. He may be having septicemia already. You see it, you know it is Fournier's gangrene. You don't need to do any tests. So there is no investigation of choice here. Investigation वगैरह नहीं है. Okay. Brain sign negative in torsion of testes. Okay, let's not discuss that here. I will answer it after this. So you don't need to investigate. You straight away go to treatment. Now, what do you do in the treatment? You do what is called as radical debridement. Debridement means excision. But what are you going to debride? You are going to remove only the skin, subacute, fascia, because it is fasciitis. You will not remove the testes because the testes are going to be spared. So please don't do orchidectomy. अभी तक सारे आप orchidectomy ही कर रहे थे. Testes are spared because testes are not going to be affected by the disease. So whatever you excise will only be the scrotum, perineum, penile skin. सिर्फ skin, subacute और fascia निकालना because it is a fasciitis. There is no orchitis in this. And after you have removed everything, the testes will be lying bare, naked. So the testes are spared. That is called as bare and naked or shameful exposure of testes. Don't say shameless testes. Say like Englishmen do, like Bailey says, shameful exposure of testes. So they are going to lie bare. Later, you can also give hyperbaric oxygen therapy. That also has benefit. Okay, in any type of necrotizing fasciitis, you can give HBOT. So this is used for Fournier's gangrene, Melanese gangrene, necrotizing fasciitis of other types of the limbs. So, okay? So this is how you are going to manage Fournier's gangrene. The question that they ask normally is testis spared, polymicrobial, and treatment. Okay. So these are some of the IMP topics that you should know, that you should study. Yeah, it is wet gangrene. Wet gangrene को ही निकालते हैं, dry gangrene को निकालने की जरूरत नहीं पड़ती. Okay. Now let's do whatever we are left with. Oh, before that, you answer this question, and someone asked me about Pren's test. Na? I will answer that also while you are answering that. See, in torsion, the pain increases. Okay. When I lift, I'm talking about lifting the testes. When you lift the testes, in torsion, the pain increases. In epididymoorchitis, since someone was asking this, in epididymoorchitis, the pain decreases. Okay, because the inflammatory tissue gets washed away. When you lift the testes, the inflammation goes away. The pain substances go away. This Pren's test is a test not of torsion. It is a test of epididymoorchitis. So when I say Pren's sign, it's not Pren's test, it is Pren's sign. Pren's sign is reduction in pain on lifting the testes in epididymoorchitis. That is the original Pren's sign. We extrapolate it to torsion. It's not meant for torsion. It is also seen in torsion where the pain increases on lifting the testes. So there is nothing like Pren's sign positive, negative. If you want to call it positive, pain should reduce in epididymoorchitis because the original, the OG, you use the word OG, the OG Pren's sign is for epididymoorchitis, not for torsion. We extrapolate it to torsion. Right? Okay. So, true statement about intermittent claudication. Now, what is this intermittent claudication? It is something that you see in a disease called as peripheral vascular disease. Simple words, peripheral arterial occlusions. Like how when you get coronary artery disease, you get angina, stable angina. Or when you get cerebrovascular accidents and you get a transient ischemic attack, TIA, not stroke. So you get those symptoms because of ischemia. Similarly, intermittent claudication is a symptom of ischemia, chronic ischemia. When does it happen? When he exercises. So when he walks, like how you get angina, when you walk, you get chest pain. Similarly, when you walk, you get pain in the exercising muscle. So is it a maximum at rest? Of course not. It is maximum when you exercise. Most common side is calf. I'm not very sure about this. Relieved after getting out of bed and walking. No. It is relieved when you take rest, not when you walk. Claudication distance varies on the same day. This is also no. It is relatively fixed. It takes time for the claudication distance to reduce as the ischemia will worsen. So answer is most common site is calf. Why is it so? Most common site is calf. Oh, asked true. Oops, lafda kar diya aap logon ne. So you should know this table. Whichever artery is blocked, the maximum symptoms will be just distal to it. So if the block is in the aortoiliac artery, in the abdomen, he will get claudication in both the buttocks. He may also get impotence. What is this called? Impotence and bilateral luteal claudication. This is called as Lerich's syndrome, where the narrowing is in the aortoiliac region. The block is a little lower down in the external iliac. He will get claudication in the thigh, which is just distal to the iliacs. Lower down, if the block is in the femoral artery, he gets claudication maximally in the calf. If it's further lower down, he will get claudication in the foot. Since this superficial femoral artery is the most common artery affected in PVD, calf is the most common site of intermittent claudication. Simple. Because the artery affected most commonly is superficial femoral artery. So claudication will commonly be seen in the calf. That is the message. Right? So that is about intermittent claudication. Okay, answer this. You are going to get questions from PVD. Yeah? So patient has bluish discoloration of the toe. Maybe he's having gangrene. Gangrene that you get in PVD is a dry gangrene. Okay. And he's having intermittent claudication. They are asking you next appropriate investigation. The first investigation will, of course, be duplex. After duplex, you can do any of these. But first will be duplex. Why do I do duplex? I want to know in which artery the flow is reduced. There are so many arteries. Where is the block? So this duplex will tell me the level of occlusion. And on duplex, I get to measure a very important parameter. That parameter is called ABPI, ankle brachial pressure index. To measure this, I measure the systolic blood pressure at the ankle. This is measured with the help of Doppler. So I tie the cuff and I use Doppler to hear the Korotkoff sounds. I divide it by the systolic blood pressure at the arm. Brachial. In a normal person, both these pressures should be the same. So normal ABPI is between 0.9 to 1.2. As the vessels in the limb will get occluded, the systolic blood pressure will fall. The more it falls, the more significant is the occlusion. And when it falls below 0.4, lesser than or equal to 0.4, this is called as critical limb ischemia. Okay, this is called as critical limb ischemia. It means now the limb is in danger of undergoing gangrene and necrosis. So whenever there is going to be critical limb ischemia on Doppler, you will have to revascularize. Right. So this is the message. If the person is having critically ischemic limb, you will come to know on Doppler. Okay? So this is how you will investigate, and this is how you are going to manage patient of peripheral vascular disease. This question comes a lot nowadays. Revascularize means you'll have to do angioplasty, like how you do in coronary artery disease, angioplasty, stenting, or CABG. Same way you'll have to revascularize lower limb PVD. It is the same. It is same like coronary artery disease. Okay, same to same. In principle of treatment, patient comes with asymptomatic varicose veins like this. Which C in the CEAP does he fall under? Okay, if the person is having varicose veins, it is C2. If it is asymptomatic, you add the letter A for asymptomatic. So answer is going to be 2A. All right. You must know the C part of the CEAP classification. Toe brachial index, it is the same as ankle brachial index only. You measure the SBP at the toe upon SBP at the arm. It's the same, toe brachial. The thing is, the toe pressures are more significant compared to ankle pressures in patients with diabetes. Because diabetes can cause calcification, because of which the ankle brachial pressure can be falsely high. You may not be able to compress the artery. It can be more than 1.2 also possible. So when I take toe pressure, उसमें calcification नहीं होती. So it is a better prognostic tool in diabetic patients. All right. This CEAP classification is something that you must know, at least the C part. And it's very easy to understand. In the first two parts, C1, C2, you only have varicosities. There are no problems apart from varicosity. In C3, C4, there are skin changes. As you can see, C5, C6, you have ulcer. So first step is you want to know, are there skin changes or not? If there are no skin changes, either you will call it telangiectasias if they are less than 3 millimeters, or you will call them varicose veins if they are more than 3 millimeters. All right. If there is only edema, it is C3. If there are other skin changes like eczema, it is C4A. If there is lipodermal sclerosis, it is C4B. If there is corona phlebitictica, it is C4C. You need to know how these skin changes are. Yeah, TV Isha XD. Wow, what a dangerous one. C5, C6 are to do with ulcer. Either the ulcer is healed or the ulcer is active. And you always take the higher score, like GCS. If he is asymptomatic, you add the letter A. If he is symptomatic, you add the letter S. So if this patient had symptomatic varicose veins, the answer would have been C to S. If the patient had symptomatic varicose veins and he had an ulcer in the past, healed, which is now healed, then what is your C? If he has a healed ulcer and currently is having symptomatic varicose veins, in that case, it would be C5. Okay, because you take the higher score. Don't just look at varicosities and say C to S. If there is a healed ulcer, even though it was in the past, the C stage will be C5, not C2. Okay. Once you've gotten a patient of varicose veins, you have to do only one investigation. That is going to be venous Doppler. You know what things you see now on venous Doppler? Mickey Mouse sign. So you do the venous Doppler and you come to know what are the areas where the problem is happening, the sites of incompetence. And then to treat, if the patient is having an early disease, not very advanced, he's not having too many problems, uncomplicated, you can give medical management. It has many things. You tell him calf exercises, calf muscle exercise. You give him these stockings. Why am I giving him these stockings, compression stockings? What are they going to do? These compression stockings, what is their benefit? Will they treat the varicose veins? Are they going to treat the varicose veins? No. So these stockings have only one benefit. They are going to provide symptomatic relief. So whatever pain he gets from the dilations, those will reduce. Symptomatic relief only. They have no role in prevention, no role in treatment, no role in progression. So if the patient wears stockings, you have to tell him that aisa nahi hai that your disease cannot get worse. It can get worse. So there is no role in prevention, no role in progression. So aisa nahi hai that I am a surgeon who is at high risk of varicose veins, so I should wear stockings and then I will never get them. Nothing like that. Right? So you give medical management. If patient gets any complication, like he gets ulcer, he gets those skin changes, or he's having too many symptoms, then you go for surgery. Now, there are many surgeries. You should know at least the important ones. These two you should know. The first one, this one, is he's putting a laser into the vein. This is called EVLA. At least the identification you should know. This is called as endovenous laser ablation. Endovenous laser ablation. So what is going to be done in this is he will pass the laser wire into the great saphenous vein and he will burn it. So the vein will get burnt from inside. Laser ablation. This is done in patients who have saphenofemoral junction incompetence, SFJ incompetence. So in these patients, you will do EVLA. It's a very nice procedure for varicose veins. It's one of the most currently used procedures. And if he has chote-mote varicosities like these, small varicosities, you can inject this thing in the vein directly. This is called as foam sclerotherapy. That is the technique of foam sclerotherapy that you are seeing here. This is called as the Tessari technique. You can see there is a IV cannula. He is attached to syringes. There is one syringe here, one syringe here. So he is going to mix the air and the sclerosant together to make a foam. This is called as Tessari technique of creation of foam. And then it will be injected into the varicosity directly. But this can only be done for small varicosities. You cannot use it on big veins. It can only be used for small varicosities. Right? So that's how you are going to manage varicose veins. Now some simpler things in life. This is a very nice question. I will discuss the question first, then you will get the answer. Trendelenburg operation आज के ज़माने में बहुत कम हो गया, in which you strip the veins. Nobody really does it except in places where they don't have laser, because it has more complications. Nerve injury is more in Trendelenburg. Yeah. What is the answer to this question? Okay, people are writing it's a venous ulcer. Neuropathy is present. You will get this question or these kind of questions. Okay. No. Don't jump to diabetic. Patient has this ulcer, which you are seeing over here. What is unique about these ulcers? They are seen on the sole, means where he is having weight. But what do you see on the border? The border is absolutely white. That white border is called as callosity. So ulcers on the weight-bearing areas with surrounding callosities are what are called as trophic ulcers. Okay, also called as neuropathic ulcers. They happen because of neuropathies. Like diabetes. Diabetes is one of the reasons. They are seen in patients with neuropathies. So if you are looking for a patient with neuropathy, answer is going to be neuropathy is present. Okay, neuropathy is present. Tropical nahi hai, trophic. It's a trophic. Trophic means nutrition in a way. In a way, it means nutrition. So if the nerves are not going, the nutrition to that part will also become hampered. Right? दिमाग काम नहीं करेगा तो खाना भी नहीं खाएगा आदमी. ऐसा ही है. So they are called as trophic ulcers. Now see what are the ulcers that you need to know. This is a trophic ulcer, another one, or a neuropathic ulcer. What you should see is this. They are deep ulcers. They are surrounded by callosity. And they are seen on the weight-bearing areas, like the sole of the foot. Because those are the areas which will get injured. And because he's having neuropathy, he will not realize that injury will be. So first it starts with a small wound, and it keeps getting irritated, and it becomes a big, deep ulcer like this. And they don't heal very easily. Diabetes is one of the reasons, but any neuropathy can give you these ulcers. Then you see these ulcers. What you are seeing in these, they are present in the lateral part of the foot, in the distal area. They are distally located. And you can see the black part. That means they are becoming ischemic. So these are called as arterial ulcers. They are seen in patients with PVD. They are seen distally. They are deep ulcers. And they have surrounding ischemia. All this is dying because of ischemia. They are ischemic ulcers. And these are the most important ones. These are called as venous ulcers. They are seen in varicose veins. As you can see, they are a typical site. This site, which is just above the medial malleolus. So they are just above the medial malleolus. This area is called Gator's area. That is a typical site where you will get these ulcers. Gator's area. And you can see the skin changes of varicose veins. Like you can see eczema around the ulcer. So these shallow ulcers in patients of varicose veins. Treatment for all of them is to treat the cause of the ulcer. Till you don't treat the cause, the ulcer will never heal. So control the diabetes, reduce the neuropathy, it will get treated. Revascularize the ulcer, PVD ulcer will get treated. Varicose veins ulcer, treat the varicose veins, ulcer will heal. Till you don't treat the cause, the ulcer will not heal. It will remain forever. Okay. Marjolin. A marjolin ulcer is in any of these ulcers, if they don't go away, if they remain forever, any of these ulcers can undergo malignant transformation. A malignant transformation in a chronic ulcer is a marjolin ulcer. So any chronic wound, chronic ulcer, if it undergoes a cancer, this cancer is a type of a squamous cell carcinoma. That is called a marjolin ulcer. Okay? treatment of marginal ulcer is like how you treat a squamous cell carcinoma. You have to do wide local excision. Okay. What is this funny looking thing? They have asked this a lot in the other exams. Very good. This is called as negative pressure wound therapy. Also called as VAC, back pressing. So this is negative pressure wound therapy. Also called as VAC. VAC stands for vacuum assisted closure. So what they do is, if there is an ulcer like this, or an ulcer like this, or like this, which is not healing, even if you have treated the cause and the ulcer is not healing, then what they do is, to promote healing, they apply the sponge, which is wrapped in a plastic with a tube. This tube is attached to a suction machine. So what will this machine do? It will give a minus 125 mm of Hg, negative suction. So it will suck, it will keep sucking. So it will suck all the fluid out. And because of this negative pressure, there will be better granulation. The ulcer will start healing. It will promote granulation. It will improve the vascularity. It will also reduce the discharge in the ulcer. So this negative pressure wound will help in healing. Bed sore will only heal after you offload it. And bed sores are very deep. They require some kind of a revascularization like a flap. So bed sores, unless they are very early, they are not going to heal. So Kushi, there is something on bed sores coming. You can answer that in a bit. Anyways, what is this? What are all these? Some pediatric surgery topics also need to be done. So in the first scenario, what you are seeing are bare intestines. They are absolutely exposed. That is called as gastroschisis. Where you see bare intestines. These are all present at birth. These abdominal wall defects are at birth. The child is born with it. They will not present at 1 year, 2 years, 10 years. By then, either the child has died or gotten treated. You see bare intestines, and there is a defect. You can't see in the image, but the defect from where the intestines are coming out is on the right of the umbilicus. So there is a hole in the abdomen. Gastroschisis is seen in teenage pregnancies. So if a teenage mother gives birth to a child, he is at risk of this defect. It is typically seen in teenage mothers. That is the first one. The second one that you are seeing, the intestines are covered in a membrane. What is that? What is that? This is called as omphalocele. Also called as exomphalus. Omphalocele or exomphalus. Here there is a defect in the umbilicus. ये नाम है ना omphalo. Omphalo means umbilicus. So there is an umbilical defect. There is a hole in the umbilicus from which the intestines are coming, but the intestines are covered by peritoneum. So they are covered by peritoneum and amnion, amniotic membrane. So they are covered, they are not bare. But this problem has a lot of other congenital abnormalities. This is associated with other diseases like cardiac defects, musculoskeletal defects. It is not going to occur in isolation. All right, that is omphalocele. All of these defects have to be closed. Means you have to put the things back inside and close the defect. Okay, they require surgery. They are not going to obviously go away by themselves. Yeah, Kushi can answer this. This is for Kushi and her Kushi. ये काय है? अभिषेक कुमार, खुशी की खुद खुशी. This is called a bed sore or a pressure sore. Any patient who is bedridden for a long time, he gets a bread sword like this. And there are the grades that you need to know. This they ask in FMG. What you're seeing here, you can see the bone. If you can see the bone, it is grade. So why does someone get pressure sore? It's because of pressure injury. So it is also called as pressure sore, also called as decubitus ulcer. Pressure sore or decubitus ulcer. So because of constant pressure, and this was asked in one of the FMG exams of more than 30 mm of edge, ये पूछा है. Because of constant pressure, the skin subdued slowly gets eroded. The most common site is the ischium, followed by the greater trochanter. Again, this is MCQ. You should know all this. Okay. Ischial tuberosity. Ischium is where you sit. अभी अगर आप बैठे हो, if you're not watching लेट के, the place where your buttocks are hitting the floor or your chair, that is the ischium. That's where you get the ulcers common. They go over a period of time. First, there is just some erythema. Then some skin will be lost. Then the full skin will be lost and subdued will be seen. If you can see subdued, it is stage 3. And if you can see any of the deeper structure like bone, it is stage 4. This requires two things. One is turn the patient in bed so that he does not get pressure injury. And normally this requires a reconstruction. Normally reconstruction with flaps. Because they are very deep wounds. Over a period of time, they become really deep. If you don't give it a flap, it will take a long time to heal. Yeah. All right. What is this? What do you see here? Nice looking thing. ये सब चीजों ना जनरल सर्जरी में आपको आनी चाहिए. So this is a parotid swelling. How do you know it is parotid? Is the swelling, if it is arising from the parotid, it will lift the ear lobule, as you can see. It lifts the ear lobule. If you feel there is a groove over here, below your ear lobule, if you go behind your angle of mandible, you can feel one groove. That is called retromandibular groove. That groove will get obliterated by the tumor or by the swelling. Retromandibular groove gets obliterated. And I can move the swelling front and back. It is mobile anteroposteriorly. What is that called? Mobile anteroposteriorly. In AP direction, it moves. What is that called? That is called curtain sign. Because जो तुम्हारे घर के पर्दे हैं वो ऐसे खोलते हैं ना, so it moves like a curtain. That is called curtain sign. When I'm going to palpate it, it may show variable consistency. Why does it show variable consistency? Some parts will be soft, some parts will be firm. This was asked in one of the entrances in NEET PG. It was not asked in FMG. Yeah. Why does it move आगे पीछे? Why does it show variable consistency? Some parts, if I'll palpate, it will be soft. Some parts will be hard. No, polymorphic nahi, because it is pleomorphic. The tumor has pleomorphic features. Pleomorphic means it's a tumor which has adenoma, yani gland. It also has connective tissue. So it's a mixed tumor. Because it is mixed, some parts of the adenoma will feel soft, some parts will feel firm, some parts will feel hard. So it has a variable consistency. Patient comes with this, how are you going to manage? What will you do first? First investigation. First investigation, investigation of choice and treatment. Yeah. Investigation. Any head and neck swelling, the first investigation is always going to be USG. Okay. USG is the workhorse imaging for head and neck. कोई भी head and neck swelling or thyroid, goiter, lymph nodes, oral cavity swellings, start with USG. USG will tell you it's a parotid swelling. Then you want to know, is it benign, malignant? The investigation of choice is going to be FNAC. What do I do once I see the swelling? Do I have to remove it? If patient says, doctor, just let it be, why do you want to take it out? It's not bothering me. I am okay. Forget the cosmetic part. Do I have to still remove it? Yes, remove. Why remove? Mandatory to remove. Why? For money. If I don't remove, how do I make 30,000, 40,000? No. Rajesh is right. It has to be removed because this is also pre-malignant. It can undergo adenocarcinomatous change. It is pre-malignant. So must remove. So surgery is the only treatment for this. And what surgery you do? There are two surgeries. The one which is commonly done is called as superficial parotidectomy. Means you are going to remove the superficial lobe. That is called as superficial parotidectomy. You can also do an other surgery which is called as extracapsular excision. It is nothing but a wide local excision. So you can do extracapsular excision. ये दो ऑप्शन है आपके पास. Commonly जो की जाती है वो है superficial parotidectomy. Superficial parotidectomy means parotid has two parts: superficial lobe, deep lobe. You remove the entire superficial lobe. Parotid gland looks like this. If you see from the side, there is a superficial lobe, very big. There is a small deep lobe. Okay, and let's say the tumor is over here. So you're going to remove the entire superficial lobe. The two lobes are separated by a nerve which passes through them, which splits into the 5 branches. This nerve here, that is the facial nerve. So whenever I'm doing a superficial parotidectomy, to separate the superficial lobe, I have to identify the facial nerve. So in the exams, they will ask you, how do you identify it? There are two landmarks that you need to know to identify the facial nerve. One is the tragal pointer over here, tragal cartilage, onlay pointer. The nerve lies just below the tragal point. So if I can find this, I know the nerve is just below it. And the second is this muscle over here, posterior belly of digastric. The nerve lies just above this. So the nerve lies between tragal pointer above and posterior belly of digastric below. All right. So this is how intraoperatively I normally locate the facial nerve, because obviously it has to be protected. Posterior belly of digastric and tragal point. Right? Okay. Let's move on to this. This is TPN. TPN stands for total parenteral nutrition. Again, one of the topics that you must know. Total parenteral nutrition. This TPN is a substitute. If the person is not going to eat by mouth, I can't give him by any nasogastric, nasojejunal feeds. I give him TPN. This is going to be given with this solution. This is a very nice bag you should see. It has 3 parts or 3 fluids. This part is the glucose. So this part is the amino acid. So there is glucose over here. This part is the amino acid. And the white part is the lipid. And all of this is going to be given intravenously. So it will give me glucose, amino acid, lipids in the form of calories. So if I can't take enterally, I can take parenterally, and these calories are going to go directly into a vein. So you put a neckline, usually you put it in the internal jugular vein, which is the most common vein, but it's not very comfortable for the patient. The most preferred is going to be the subclavian. This is ideal. So I put the neckline into these veins, and from that neckline, I give this TPN. It gives me a lot of calories. It gives me a lot of nutrition. Can't eat by mouth, can't eat by GIT, can take TPN. What is the problem with TPN? CH fat AA 24 hours. Yeah. What is the problem with TPN? There are many problems. The problems can happen because of the central line, because the neckline will give all the TPN, it will be there for a long time. So the most common complication is going to be central line or catheter infections, catheter sepsis. This is the most common complication overall. There can be problems of technique, like I have to put a neckline, I can injure things. So the most common technical complication is pneumothorax. I can puncture the pleura by mistake. And there can be problems related to feeds. Because understand, you have a GIT for a reason. When I eat, if I overeat, I can vomit or I can get diarrhea. If I eat less, my GIT tries to extract the maximum. My GIT is a filter to take or release as per my body needs. If I'm putting in the vein, there is no control. Whatever is there in the TPN is going directly. So I can get overfed. I may receive more than what I need. So I can get hyperglycemia because of overfeeding. I can get hyperlipidemia and so on and so forth. On the other hand, I can also get deficiencies. I may not get all that I need. Typically vitamin deficiencies, electrolyte deficiencies, they are quite common because there is no control. जो गया गया, जो नहीं गया नहीं गया. There is no filter. What goes directly in the vein has gone. And the last is, if I suddenly start feeding, I get a phenomena which is called as re-feeding syndrome. This is going to be seen in someone who has been chronically starved. So, अगर उसने बहुत दिनों से कुछ भी खाया पिया नहीं है, and suddenly you start feeding him, he can get re-feeding syndrome, in which he gets reduced phosphates and reduced magnesium. Because suddenly your ATP starts utilizing your phosphates and magnesium, and you get these deficiencies suddenly, and the person can get arrhythmias. He can get convulsions. So arrhythmias, convulsions, they can occur. This is what is called as re-feeding syndrome. They will give you a scenario: patient who was chronically starved, maybe he had C. esophagus, suddenly you are giving him TPN, and in that case, he becomes breathless, he becomes tachycardic, he becomes drowsy. What do you suspect? That is going to be re-feeding syndrome. What do? You give him the electrolyte corrections. He will become all right. Yeah. What is this? Only 2 slides left. What is this image? This is Veress needle, which is used in closed technique of pneumoperitoneum. Okay, this is used in closed technique of pneumoperitoneum. This they have asked so many times. I don't know why. Their favorite question. What is this image? Dermoid cyst. What type of dermoid is this? What type of dermoid is this? Implantation. कुछ भी. Implantation. This is a congenital dermoid cyst. A dermoid cyst is going to happen in areas where the bones fuse, typically on the face. Bones are formed from mesoderm. Just above the mesoderm is ectoderm. So when the bones are fusing, like the bones over the face, the ectoderm can get trapped. Some part of the ectoderm can get trapped and form a cyst. So these are congenital dermoid cysts. They will be seen at the sites where the bones fuse. Like they will be seen in the midline, in the inner or outer canthus of the eye, in front of the ear, behind the ear, in the midline in the face, like floor of the mouth. Those are the places where the facial bones will fuse. गलती से उसमें ectoderm, that's why dermoid gets stuck and forms a cyst. So this is a congenital dermoid. Treatment of congenital dermoid is going to be excision. Dermoid cysts, all cysts, either you do nothing or you do excision. Incision and drainage in surgery is only for one thing. Only one thing in surgery you will do: incision and drainage. Only one, abscess. Okay, it's a thumb rule. Cyst, either you excise it or do nothing. Abscess you will do IND. ओके और कोई बीमारी में आईएनडी नहीं करते हैं सर्जरी में, कोई भी सिस्ट में आईएनडी मत करना, ठीक है. Yeah, so we did many things. Now I can take whatever you want extra. We have done a lot in I don't know 10 to 9 15 with breaks. आप लोगों ने बहुत चीजें पढ़ी है, बहुत चीजें सुनी है. आज कौन सा एब्सेस बताया था? ब्रेस्ट एब्सेस एस्पिरेट किए थे ना, ब्रेस्ट एब्सेस. ओके, नाउ व्हाट इज डंपिंग? Dumping is going to happen. Let me see if there is any page left here. Okay, we have a page here. I'll tell you about dumping. Dumping is going to happen in patients in whom the food will reach the intestines very fast. For example, let's say I did a gastrojejunostomy for peptic ulcer. Okay, so I joined the stomach to the jejunum. So when he's going to eat food, the food will go from the stomach very quickly into the jejunum. It will get dumped. Because the food gets dumped, there can be two problems. One is called early dumping. Other is called late dumping. Why is it happening? It's because food is getting dumped quickly into the intestines. Normally you have a pylorus, so what you eat stays in the stomach for some time. Slowly it goes into the duodenum jejunum. Now you don't have a pylorus, so food gets dumped. Now what happens in these cases? In early dumping, this will happen usually within 10 to 20 minutes. After eating foods which have a very high sugar, no, not very high sugar, sorry, very high osmolarity. Foods which are very osmotic, like fruit juices, ORS, fruit juices, limbu pani, ऐसा कुछ आपने पिया, which has a high osmolarity, the moment it will reach the intestine, because it has a lot of osmotic molecules, it will suck all the liquid from your blood into the gut. So there is going to be rapid absorption. There is going to be rapid absorption. I won't use the word absorption. There will be a rapid pull, not absorption. There will be a rapid pull of fluid into the gut. So whatever serum is there in your blood, it will get sucked into the jejunum. And because the fluid is getting sucked into the jejunum, there will be a reduction in blood volume. The fluid part is gone, blood will become thick. So the person gets hypotension suddenly. So within 10-20 minutes of food, if you get hypotension, how do you know he has hypotension? He will start feeling lightheaded. Lightheadedness. He will feel dizzy. Sometimes they even get diarrhea, bloating, because of the increase in water in the gut. Dizziness. He will feel bloated. This is going to be early dumping. So early dumping, hypoglycemia, hypotension. Late dumping happens usually within 1 to 3 hours after meal. When I have a food which is a high amount of sugar, refined flour, maida, momos, those kind of foods, pastries. When I have food which is high in sugar, suddenly it will get absorbed. So there will be a sudden sugar spike in my blood. To compensate the sugar spike, my pancreas will release a very high amount of insulin, more than required. And because of this very high insulin production, I get a rebound hypoglycemia. So late dumping, hypoglycemia. Early dumping, hypotension. All this can be documented. If I check his sugar, it will be 50, 55. So how will the person present? He will present with features of hypoglycemia. He'll get tremors, neuroglycopenic symptoms. He'll get tremors, palpitations, beta sympathetic activity, sense of impending doom. You check his sugar, it will be very low. Both of these can be treated by dietary modifications. Okay, the management is dietary modifications. All right. That is about dumping. Yeah, small frequent meal. Avoid these triggers. That's what you got to do. The triggers have to be avoided. Nothing else. और कुछ चाहिए? Pediatric GCS मत करो. I don't think you need pediatric GCS. Don't worry about it. Refeeding pathophysiology is if you are starved and suddenly I give you a lot of nutrition, all the nutrition will get used in your biochemical cycles to produce ATP. So whenever ATP is produced, adenosine triphosphate, your phosphate gets used up. Because phosphate gets used up, you get hypophosphatemia. Hypophosphatemia, hypomagnesemia, these are all parts of the biochemical cycles. That is refeeding syndrome. Okay. Convert 2 to 1. Motivation. You want motivation. I think the amount of stuff we have done is more than enough. I only want you to revise whatever you have studied before. And you obviously have to at least go through the PYQs in the days to come. So first thing is decide how much time you're going to give to surgery in the days to come, considering which exam is left. So your idea has to be, if I am, let's say, give one more day to surgery, in that one day, how much do I want to revise? You should at least revise what we have done, plus whatever you have collected over time. That's it. Burns questions can come, yeah. Many things can come. How do you keep your mind during UGs and how do you? I kept my mind. We did not have any scope for FOMO. If you don't have FOMO, you can manage. That's the only thing. Okay, okay, guys. Thank you so much. All the best. Study hard. Best wishes for your exams.